In a previous video, we discussed the EEG waveform and spectrogram and how general anesthesia with different anesthetic drugs results in distinct patterns. In this video, we'll be discussing Propofol. Propofol is the most widely administered anesthetic drug. It is used as an induction agent for sedation and maintenance of general anesthesia. Here are several examples of the typical EEG waveform and spectrogram that we see while propofol is being used to maintain general anesthesia in young adult patients. Propofol's pattern is characterized by high power exhibited primarily in two frequency ranges, between 0 and 4 Hz corresponding to slow delta oscillations and around 8 to 12 Hz corresponding to alpha oscillations. When propofol is administered as a bolus for induction of general anesthesia, the EEG changes within 10 to 30 seconds from an awake pattern that typically consists of low amplitude gamma and beta oscillations to a pattern of high amplitude slow and delta oscillations. In the EEG spectrogram, this appears as an increase in the power between 0 and 5 Hz. This transition to a slow delta pattern coincides with the loss of responsiveness, loss of the oculocephalic reflex, apnea, and atonia. As the initial, profound effects of the bolus dose of propofol recede, the EEG then evolves into a slow delta and alpha oscillation pattern. The transition time from the slow delta pattern to the combined slow delta with alpha pattern depends on how profound the bolus dose effect was. During maintenance, we observe our typical propofol pattern. Following the discontinuation of the propofol, the typical slow delta and alpha oscillation pattern is gradually replaced by higher frequency beta-gamma oscillations with lower power. This can appear as a zipper opening type of pattern as the alpha pattern drifts to higher frequencies. But why do we see this particular pattern with propofol? To answer this, we need to look to the brain and propofol's effect on the underlying neurophysiology. Propofol is an agonist at GABA-A receptors. GABA-A receptors are widely distributed throughout the cortex, thalamus, brainstem, and spinal cord. During normal consciousness, there is a balance between excitatory and inhibitory inputs. Propofol shifts this balance to favor inhibition. In the cortex, propofol enhances GABA-mediated inhibition of pyramidal neurons, which decreases excitatory responses. In the thalamus, at the thalamic reticular nucleus, propofol enhances GABAergic inhibition, serving to decrease excitatory inputs to the cortex. Propofol also interacts with the preoptic area of the hypothalamus to enhance inhibition of the principal arousal centers of the hypothalamus, midbrain, and pons. Inhibition of these ascending arousal centers in turn decreases their input to the cortex, thereby decreasing cortical activity. So, how does this relate to our EEG signal? During consciousness, the cortex and thalamus are in constant communication across a wide range of frequencies. The thalamus quickly relays information from different sensory modalities to the cortex, which processes the information before relaying information back to the thalamus. When propofol is administered, it enhances inhibition in the cortex and thalamus, serving to slow down communication. Rather than communicating across a wide range of frequencies, communication is essentially limited to a small bandwidth of frequencies, around 8 to 12 Hz. Hence, the alpha component of our typical propofol EEG pattern. Now, how about the slow delta oscillations? Neurons across the brain alternate between activated on and inactivated off states. During off states, they are not capable of communication. Shortly after the administration of propofol, synchronization of these on-off states between distant brain regions becomes fragmented. Activated neurons in one area of the brain are unable to propagate information effectively to distant inactivated regions. Local brain regions can continue to communicate, but there is now impaired global cortical communication. The slow delta oscillations observed in the EEG are markers of this fragmentation of intracortical activity. Therefore, our typical Propofol EEG pattern can be traced back to two mechanisms through which propofol is thought to induce unconsciousness: dysfunction of thalamus and cortex communication and interruption of intracortical communication. Please visit the associated course to earn CME and learn more about the use of the EEG for anesthesia practices. In the next videos, we will look at the EEG patterns of other common anesthetics.